First and foremost, I would like to thank KPA for giving me an opportunity to speak on this topic, What's Spine, um, in this KPA platform webinar series, Open Learn. Today, I'll be speaking about What's Spine. Coming to the history of TB spine, TB bacilli has lived with mankind since time immemorial. It was observed in Egyptian mummies back in 9000 BCE. It was described in Indian treatises as Charaka Samhita and Shushruta Samhita as Yakshma, which is considered as tuberculosis. It was in 1779 that Sir Percival Pott described tuberculous spondylitis and its presentation of paraplegia in patients with kyphotic deformities in European population. It was in 1862 Robert Koch discovered the tubercle bacillus. Coming to the epidemiology, as per WHO report, TB is one of the top causes of death worldwide. That is sixth most common. A total of 1.4 million people died from TB in 2019. 10 million people fell ill with TB worldwide in 2019. Eight countries account for two-thirds of the total TB burden. India tops the list with 26%. There has been a 10% increase in MDR-TB, that is multi-drug resistant TB, from 2018 to 19. Globally, there has been a fall of TB incidence at 2% per year. 60 million lives has been saved through TB diagnosis and treatment between 2000 and 2019. As per Indian data, the incidence of extrapulmonary tuberculosis is at 3%. Skeletal TB contributes to 10% of extrapulmonary TB. Spinal TB accounts for 50% of the skeletal TB, and it's common in children and young adults. Occurs commonly within the first 3 decades of life. Men and women are equally affected. Spinal tuberculosis is caused by Mycobacterium tuberculosis complex, the most common being Mycobacterium tuberculosis. About the organism, the cell wall is rich with peptidoglycan and lipid layers. They are slow growing, fastidious, aerobic organisms. They are acid fast. The doubling time is 18 to 20 hours in favorable conditions, and they remain dormant in unfavorable conditions. Coming to the risk factors for tuberculosis, the main risk factors are poverty, overcrowding, intravenous drug abuse, HIV patients, alcoholics, elderly, and patients with poor nutrition, diabetes, chronic lung diseases, organ transplant recipients, long-term steroid therapy, and cancer chemotherapy. Coming to pathophysiology, the primary site of infection is the lungs and lymph nodes of mediastinum, mesentery, gastrointestinal tract, and genitourinary system. As you all know, the infection starts usually in the lower lobes, which is called as the Gons focus. Then it forms the Gons complex. There is lymphatic and hematogenous dissemination, where uh, the dormant bacilli are lodged in several organs, and there is reactivation in the adult life to form cavitary lesion and fibrosis, usually in the upper lobes, and subsequently extrapulmonary manifestations. The most common site of spinal TB is thoracic spine, especially the thoracolumbar junction, followed by lumbar spine, cervical spine, and sacral spine. Spinal TB is always secondary. There are different modes of spread. The most common being hematogenous route from the primary focus through paradiscal arteries. Second way of spread is through Battson's venous plexuses, which are valveless venous system. And third is through paraaortic lymph node spread. The pathogenesis includes there is a be phagocytosis of the tubercle bacilli by monocytes and macrophages. This leads to formation of classical tuberculous granulomas with Langerhans Jain cells. There are small patches of central caseous necrosis. All these coils to form a large yellow mass, and they break down in the center to form cold abscess. There are three main mechanisms of destruction of the vertebra. One is osteoporosis due to hyperemia, and the second thing is the osteolytic lesion because of the bacilli itself. Third thing is ischemic necrosis due to peri or endarteritis. All these three mechanisms leads to destruction of the vertebra, collapse, and progressive deformity, that is kyphosis or Kibbe's deformity. There are mainly two types of skeletal tuberculosis, that is caseous exudative type, which is most common, and granular type. In clinical practice, both types coexist. Coming to the sites of spinal tuberculosis, there are five sites which are affected. Most common is paradiscal, where the contiguous areas of adjacent vertebrae along with the intervening discs are affected. This usually through the paradiscal arteries. Second most common is the central, where a single vertebra is affected, which leads to early collapse and weakening of the vertebra. Here, the disc space is normal. In anterior, the location is between the anterior longitudinal ligament and the periosteum, where infection starts and spreads under the anterior longitudinal ligament. Fourth one is posterior, where the posterior elements are affected, which includes pedicle, lamina, spinous process, and transverse process. Fifth one is facet, which is rare, or synovial joint involvement. This is the same thing with MRI involvement, with paradiscal involvement, central, anterior, and posterior. There are two types of TB spine presentation. First one being typical, where paradiscal, it's also called as paradiscal, where it involves the vertebrae with the intervening disc. Atypical constitutes 2% of the patients, where there is concentric vertebral collapse, also called as vertebra plana, isolated neural arch involvement, ivory vertebra, where the vertebral body appears sclerotic, circumferential vertebral involvement, skip lesions, multifocal osseous involvement. All these are atypical radiographic presentations. Prolapsed intervertebral disc, isolated cold abscess without bony involvement, intraspinal pure soft tissue granulomas, all these are atypical clinical presentations. It's important to know that spinal TB is a chronic granulomatous disease and it's a paucibacillary disease. And uncomplicated spinal TB is a medical disease. Coming to the clinical features of TB spine, there are five main features. First thing, most common is back pain. Next comes constitutional and specific symptoms, then paravertebral abscesses, kyphotic deformity, and neurological deficits. Most common is back pain, where there is chronic inflammation. It typically produces nagging pain. Para and prevertebral abscess produces aching pain, and spinal segmental instability produces severe pain. Exacerbations occur at night, which typically produces night pain or night cries, and this happens because the loss of protective muscle spasm, where there is rubbing of the inflamed surfaces of the vertebra, leading to typical night cries. There is bone destruction and instability, which leads to rest pain, which is pathognomonic of TB spine, and radicular pain is uncommon. Constitutional symptoms include malaise, loss of weight, appetite, evening rise of temperature, night sweats. All these constitutional symptoms are more common in patients with pulmonary TB and malnutrition. Specific symptoms include night pain, stiffness, deformity, restricted range of motion, abscess formation, and neurological deficits. Cold abscess is formed by collection of products of liquefaction and reactive exudation. The composition of cold abscess includes serum, leukocytes, caseous material, bone debris, and tubercle bacilli. Paravertebral abscess are diagnostic of spinal TB. It takes the path of least resistance. Distally, it tracks through various planes from the region of involvement: perineural, perivascular, intramuscular, subpleural, and retroperitoneal. The tracking of cold abscess in the cervical spine, it presents as retropharyngeal abscess, which clinically presents as dysphagia, hoarseness of voice, and respiratory stridor. Swelling can occur either in the anterior or posterior triangle of the neck or along the brachial vessels as axillary swelling. In the thoracic region, it typically forms a fusiform paravertebral swelling, which in radiographs appear as bird nest appearance. Along the intercostal space, there is a swelling in the chest wall. Anteriorly, it can present as a mediastinal mass. In the lumbar region, the swelling can occur in the lumbar petit triangle, in the groin as psoas abscess. Along the femoral vessels, it can abscess can be formed in the Scarpa's triangle anteriorly or along the gluteal vessels in the gluteal region. Kyphosis is um, one of the deformity or most important deformity of anterior vertebral disease, typically of spinal tuberculosis. Single vertebral involvement leads to knuckle deformity. Two or three vertebrae gives rise to gibbous deformity, and multiple adjacent vertebrae gives rise to rounded kyphosis. Neurological involvement can occur in 10 to 43 percentage of the patients. It can occur both in active and healed stages. In the active stage, the cause for neurological deficit is inflammatory edema, the tuberculous granulation tissue, abscess, caseous tissue, and rarely ischemia of the cord. In late stages, or this happens in the healed stage, the causes being TB caseous tissue, the debris, sequestrum of vertebral body or the disc, internal gibbous, stenosis of the vertebral canal, and severe kyphotic deformity. It was Griffith, Seddon, and Rowe in 1956 in during the pre-antitubercular era gave classification of the Pott's paraplegia. It's divided into early onset paraplegia and late onset paraplegia. Early onset happens during the active stage of the disease. This is usually less than 2 years and is associated with good prognosis. Late onset occurs during the healed stage where it takes more than 2 years for the onset and it is associated with poor prognosis. Clinical features of Pott's paraplegia include spontaneous muscle twitching in lower limbs, clumsiness while walking, extensor plantar response, exaggerated reflexes. There is sustained clonus of patella and ankle, and motor is affected more than the sensory. Staging of Pott's paraplegia, there are four stages. Stage 1 is negligible, where the patient is unaware of the neural deficit, whereas the physician detects plantar response or ankle clonus. In stage 2, it is mild. Patient is aware of the deficit but manages to walk with support. In stage 3, which is moderate, patient is non-ambulatory because of paralysis and extension, and the sensory deficit is less than 50%. In stage 4, which is severe, it includes stage 3 along with flexor spasms, paralysis in flexion, and sensory deficit which is more than 50%, and sphincters are involved. Coming to prognosis of recovery of cord functions, in stage 1 and stage 2 is associated with good prognosis, shorter duration, early onset, slow speed of onset, all these are associated with better prognosis. Coming to the age, younger the age, general condition being good, active vertebral disease are all associated with better or good prognosis. If the kyphotic deformity is less than 60° and the cord on MRI looks normal, all these are also associated with better prognosis. Kumar has given a clinical radiological classification in 1988 into 5 stages. The pre-destructive stage, there is straightening of the curvatures of the spine and there is spasm of the paravertebral muscles. In early destructive phase, there is decreased disc space with paradiscal erosions. Mild angular kyphosis, there is kyphotic angle between 10 to 30°. In moderate angular kyphosis, the kyphotic angle is between 30 to 60 degree, and severe kyphosis, there is kyphotic angle of more than 60 degrees. Coming to the diagnosis, uh, we'll cover it under four heads: clinical features, lab investigations, microbiological investigations, and radiological investigations. The most important ones in the lab investigations are hemoglobin, which is usually low. ESR is a sensitive marker of infection, and this is markedly elevated, which is more than 20 mm per hour. Serial measurement is used to assess the response to treatment, and it normalizes within 3 months of ATT. Failure to normalize indicates persistent disease activity. Liver function test is important because most of the ATT drugs are hepatotoxic, and this is done to assess the status of the liver before ATT. And of course, HIV test. The not useful lab tests are CRP, because CRP can be increased in many other infective conditions. Montu test is not useful. Quantiferon TB gold test, it has been banned. IgG and IgM antibodies and blood PCR tests are not to be done. Microbiological investigations include mycobacterial culture and smear, molecular methods like a gene expert test, and biopsy. Culture, which is the gold standard test which confirms the diagnosis. It acquires antibiotic sensitivity to guide therapy. Culture is taken from bone and abscess walls, and pus sample is sent in saline. Agar media, which is the Bactec system, are the standard culture media, and they allow early drug susceptibility assessment. Results are obtained usually within 2 weeks, that is between 4 to 14 days. LG medium culture takes 6 to 8 weeks. AFB smear, ZN stain technique is used. It shows bright red bacilli. Sensitivity is around 25 to 75 percentage. Specificity is around 99. The molecular test, gene expert PCR test is done, especially gene expert MTB, that is Mycobacterium tuberculosis rifampicin test, which is a fully automated diagnostic test. Results are obtained as early as 90 minutes. Sensitivity of up to 95 percentage and specificity of up to 96 percentage, and this aids in identifying resistance to rifampicin. The other PCR tests are um, Gene Expert MTB RIF Ultra, which is a next generation test. It is recommended by WHO in March 2017. It has got a better detection rate of Mycobacterium tuberculosis with low bacilli count, and it is especially um, important pediatric and extrapulmonary specimens. The newer ones are Gene Expert Omni, which is currently under development for testing TB and rifampicin resistance, and it is expected to be less expensive. In biopsy, the most common cytological findings are epithelioid cell granulomas, multinucleated Langerhans giant cells, inflammatory lymphocytic infiltration, and central caseous necrosis. Biopsy is something which is mandatory before starting ATT. Preferably, it is obtained fluoroscopy or CIAM guided. Sensitivity is about 53 to 81 percentage, and multiple tissues are sampled from the abscess, bone, and the disc. There is no need to stop ATT before surgery. Radiological investigations include plain radiographs, CT scan, and MRI. Early features of plain radiographs include vertebral osteoporosis, narrowing of joint space, and indistinct paradiscal vertebral margins, paravertebral soft tissue shadow. The late features include vertebral collapse, kyphosis, lateral translation, asymmetrical wedging, and concave erosions over the anterior surface of the vertebral bodies, which we call it as aneurysmal phenomenon. Chest X-ray, it is essential because 60 to 70 percentage of the spinal TB may have active pulmonary lesion. CT scan shows the extent of bony destruction, and it allows early identification of posterior element involvement. It helps in planning percutaneous biopsy. Calcifications in the abscess is pathognomonic feature of in CT scan. TB in areas which is not clearly defined in X-rays can be picked up by CT, like in areas such as craniovertebral junction, sacrum, sacroiliac joint, cervicodorsal region. MRI scan is the gold standard radiological investigation. It allows early diagnosis. The features favoring diagnosis of TB spondylitis include a well-defined paraspinal abnormal signal, thin and smooth abscess wall, paraspinal or intraosseous abscess, subligamentous spread, involvement of multiple vertebral bodies, vertebral collapse, and thoracic spine involvement. MRI is highly sensitive and specific for spinal TB. Extension of disease can it shows extension of disease into the soft tissues. It also shows the spread of the abscess in the epidural space, and it clearly demonstrates the neural compression and changes of discitis in the form of edema. It also identifies multifocal or skip lesions. And MRI is also used to assess response to treatment and regression of the disease. Coming to differential diagnosis, there are plenty. The most important ones are pyogenic spondylitis, basilar fungal spondylitis, hemangioma, multiple myeloma, secondary in spine lymphomas, eosinophilic granuloma, which presents as vertebra plana, osteochondrosis of spine, spondylolisthesis, osteoporotic fragility fractures, and the rare one is hydatid disease of the spine. A special mention about spinal tumor syndrome. Here, it presents with neurological complication. There is no obvious osseous lesion on conventional radiographs. X-rays look normal. So, what is the investigation of choice? MRI. MRI is the best investigation. The cause of spinal tumor syndrome include diffuse extradural granuloma, localized intramedullary tuberculoma, and peridural fibrosis. And it's treated with ATT, especially in intramedullary tuberculoma, and surgical decompression is done for extradural granuloma. Dr. Rajashekaran has given spine at risk signs. There are four signs which include facet subluxation, posterior retropulsion, lateral translation, and toppling sign. This is important because children who are more likely to have progressive deformity can be identified early in the course of the disease, and this allows for early intervention in the form of surgery before the onset of progression of the deformity. So, children less than 10 years, 3 or more vertebral body involvement, C7 to L1 vertebral involvement, all this need close observation. Coming to treatment, it's mainly divided into medical treatment, which essentially is with chemotherapy, with ATT, and surgical treatment. In medical treatment, we have uncomplicated and complicated. In uncomplicated, chemotherapy is mainly with ATT, which is the mainstay of treatment. In surgery, surgery is required only in few cases, about 5%. Complicated spinal TB, here also chemotherapy is the mainstay of treatment, and surgery is required in about 60% of the cases. The first line ATT drugs are the most effective agents against active tuberculosis, against active which are is active against tuberculosis, which include isoniazid, rifampicin, ethambutol, pyrazinamide, and streptomycin. Second line ATT drugs are usually the fluoroquinolones and injectable drugs like kanamycin, amikacin, and capreomycin. Coming to the recommendations, which is the important part, recommendations for ATT in spinal TB. The WHO recommends 9 months, that is 2 months of intensive phase and 7 months of continuation phase. American Thoracic Society also recommends 9 months, that is 2 plus 7. Canadian Thoracic Society recommends 9 to 12 months, that is again 2 plus 10. But what we follow is Index TB guidelines by Ministry of Health and Family Welfare, which is about 12 months, which includes 2 months of intensive phase, which includes drugs like INH, rifampicin, pyrazinamide, and ethambutol, and 10 months of continuation phase with isoniazid, rifampicin, and ethambutol. And They have also added that it can be extendable to 18 months on a case to case basis. So the consensus is ATT for spinal TB is between 12 months to 18 months. Dr. Tully in 1975 has given a middle path regime, and it includes intensive phase, continuation phase, and prophylactic phase for a period of about 5 to 6 months, 7 to 8 months, and 4 to 5 months, respectively. And the rationale behind middle path regime is all spinal TB cases do not require surgery. Only those which don't respond to conservative measures should be operated. And in this regimen, treatment is with ATT, rest, and spinal braces, and supportive therapy is given with multivitamins, hematinics, and high protein diet. And Dr. Tully has shown excellent outcomes with this regimen. A small note about drug resistance, where MDR-TB is defined as a resistance to both isoniazid and rifampicin. XDR-TB, that is extensive drug resistance, is defined as resistance to any fluoroquinolone and at least one injectable second-line antibiotic in addition to isoniazid and rifampicin. TDR-TB means total drug resistance, which is defined as resistance to all first-line and second-line drugs. Coming to the surgical treatment is done uh, either to establish a diagnosis by CT guided percutaneous biopsy or by an open biopsy, or to treat spinal instability, neurological deficit, and deformity. The indications for surgery without neurological deficit is diagnosis when the diagnosis is uncertain and open biopsy is indicated. When there is mechanical instability, where there is panvertebral disease, means both anterior and posterior elements are involved. There is bilateral facet joint disease. When there is suspected drug resistance, where there is inadequate clinical improvement or deterioration on ATT, or there is spinal deformity, that to severe kyphotic deformity, and children with high risk of progression of kyphosis with growth after healing of the disease. Indications for surgery with neurological deficit include neural complications developing or getting worse or remaining stationary during the course of non-operative treatment, um, the time of 3 to 4 weeks, or if there is paraplegia of rapid onset, spinal tumor syndrome, neural arch disease, severe paraplegia, or painful paraplegia in elderly patients. How do we monitor the response to treatment? By clinical assessment, where the patient regains appetite and weight by 6 weeks, spinal pain and muscle spasm reduce. Hematological assessment, where the ESR takes 4 weeks to show changes and it usually normalizes within 3 months of ATT. Radiological assessment, by X-rays, the abscess shadow decreases in size and there is sclerosis of bone which begins by 3 to 4 months. There is complete bone effusion which occurs at 9 months, and every 3 months following initiation of treatment. Follow-up X-rays is suggested every 3 months following initiation of treatment. MRI is also used to assess response to treatment and regression of the disease. Here, we look for resolution of marrow edema, replacement of marrow by fat, seen as bright signal on T1 images, and complete resolution of paravertebral abscess. Follow-up MRI is suggested at 6, 9, 12, and 18 months following initiation of treatment. The goals of surgical treatment includes decompression, where you debride and drain the large abscess, decompress the spinal cord and neural structures, and second goal is deformity correction, where you prevent or correct the spinal kyphotic deformity, and to achieve stability by reconstruction of the anterior column and spinal stabilization with instrumentation. Factors to be considered for surgery are the age of the patient, the location of the bony lesion, presence of comorbidities, severity of kyphosis, number of levels affected, experience of surgeon, and preference of the surgeon. Surgical approaches include anterior decompression and stabilization, combined anterior decompression with posterior stabilization through two approaches. This is becoming obsolete now, um, because the because of the morbidity of two combined approaches. All posterior approach for anterior decompression and posterior stabilization. This is the current standard of care. Surgical techniques for cervical spine. Standard anterior technique for debridement and decompression is used for cervical subaxial lesions. For thoracic spine, transthoracic approach, retropleural approach, and transpleural approach is done. In thoracolumbar and lumbar spine, retroperitoneal approach is done. So we have come to the last slide of this talk. The take-home message for spinal tuberculosis includes: uncomplicated spinal tuberculosis is a medical disease. Culture, biopsy, and MRI are key for diagnosis. ATT chemotherapy is the mainstay of treatment. Surgery is indicated. Surgery is done when indicated and tailored individually. Thank you.